Hi, everyone, and welcome to today's Pulmonary Fibrosis Foundation Disease Education webinar. I'm Dr. David Lederer, Senior Medical Advisor for the Foundation. Today, we're happy to share with you some research findings that were presented at the American Thoracic Society meeting held in San Diego last month in May. And I'd like to introduce our speakers for today. We have two pulmonologists and experts in interstitial lung disease who are clinical and thought leaders in the field. We have Dr. Sonye Danoff from Johns Hopkins in Baltimore, Maryland, which is one of our Pulmonary Fibrosis Foundation care centers. Welcome, Dr. Danoff. And Dr. Marilyn Glassberg from the University of Miami, another one of our PFF care centers, and looks like we're having a little technical problem, but we'll fix that in just a moment. Sorry about that. Dr. Glassberg is from the University of Miami, Miller School of Medicine. And before we begin, I want to give you a quick reminder that we are not providing you with any medical advice or recommendations, as noted here in this slide. This webinar is really for informational purposes only. We'd ask you not to make any changes to your medical care without talking to your doctor. So do we have Dr. Danoff and Glassberg on the line?
I hope you can hear me now.
We hear you perfectly, Dr. Danoff. I'm going to let you go ahead and take it away.
All right. Thank you so much. And thank you to the Pulmonary Fibrosis Foundation and its leadership for inviting us to share some of the really exciting results that we heard about during the ATS. I'd like to just kind of set the framework, and then I'm going to introduce my colleague, Dr. Glassberg, who's going to kick off with some of the new findings. Clearly, this was a multi-day, very active and exciting conference, and there's far too much. I'm going to talk about 4 of the trials, and we're going to only sample a little bit of the data that was given because it's just way too much to present in detail. I do want to talk about a few of the new diagnostic proposals that have been made in terms of how to diagnose certain of the types of interstitial lung disease, and then I'd like to finish off by just talking a little bit about some of the new areas of ILD research. There was lots and lots on the biology of ILD and pulmonary fibrosis, but I think we're going to have to wait to a later seminar to talk about that one because there's just too much to discuss. So this is what we're going to cover: 4 clinical trials, the diagnostic guidelines that are coming out on IPF and hypersensitivity pneumonitis, and then we're going to talk about a new area, which is immune checkpoint inhibitor-associated pneumonitis. And now I'd like to turn it over to my colleague and friend Marilyn Glassberg from University of Miami. She's going to give you an overview of some of the clinical trials that were discussed at the ATS.
Hello, everybody. Thank you, Sonye. And thanks, David, and thanks, PFF, for putting this together for the patients. I think there's a lot of information here, nothing that's going to change our care at the moment, but I think very exciting areas of research. So let me first start by saying that most of the trials that were presented were actually in one mini-symposium on Sunday that lasted a couple of hours and covered several trials, of which we're only going to go through 4 of them. There were also posters that were presented on other trials. And as Sonye said, there's just too much information, and really it's at its infancy in a lot of the areas. But I think it's important that we go through these 4. The phase 2 trial of laparoscopic anti-reflux surgery, known as the WRAP trial. This is trying to address the role of reflux and management of reflux in patients with IPF. The second trial that I'm going to go through is the phase 2 trial of the autotaxin inhibitor from the company Galapagos, GLPG 1690, known as the FLORA trial. And the phase 2 PBI 4050 trial, this is one that was done alone or in combination with pirfenidone and nintedanib, and I'm going to explain these drugs with a diagram in just a minute, so just hold on. And then phase 2 of the Petraxin 2, also done with pirfenidone or nintedanib. So let's look at a diagram here from Dr. Martin Kolb, who put this together at the end of last year, and you look at this and you go, oh my goodness, what is all of these dots and things here? And this is just to show you how much work is being done to try to understand the components and the parts of the fibrotic airway that can be attacked by developing drugs by looking at immune system, by trying to figure out, and each one of those dots is actually a drug that's been developed. So pretty interesting stuff. You'll see some of the ones that we're going to talk about, but they're coming through in different parts. So some will be addressing the macrophages, some will be addressing the fibroblasts that you've all heard about that are responsible for the part changing the structure of the airway, the cross-linking, the proliferation. You're going to see a lot of things that this complex little diagram tries to say, look how much is being done. It's really remarkable. So let me start with the WRAP trial. This is a trial that was done at basically 5 clinical sites and was sponsored by the NHLBI. The slides, most of them are courtesy of the main investigator on this study. It's Ganesh Raghu from Seattle. And you can see in this map, the majority of the patients indeed did come from Seattle. In fact, 33 of the total. So really not wide representation. Some centers, as you see, only had 1 or 2 or 3 patients. Some had 4, but most coming from the West Coast. That becomes important because of the type of patient selection. But remember, this is an early trial that we're trying to see the role of actually using surgery instead of using drugs to treat your reflux. And this shows you the effect on lung function. It's a 48-week study that's shown to you on the x-axis at the bottom where it says weeks from randomization. And then the y-axis shows you the change in the lung function. The dashed line is patients that didn't get surgery, and the black line is those that did. And you can see that there is a very slight difference. This didn't achieve statistical significance, but certainly suggesting that there may be a role in patients who have surgically correctable disease that it be done. This now, in the next slide, shows you what are called secondary endpoints. So the primary endpoint was lung function. The secondary endpoint is to look and see how many patients, did anybody die? Did they have more decline with their lung function? Did they get hospitalized more? And you can compare the columns by looking at surgery here and then looking at no surgery here. So even numbers of patients getting both. And you can see in the no surgery column that there were some deaths, that there was a little bit more decline and some more hospitalization. And so they did achieve, even in a small group of patients, some very interesting data. What you see, though, that's in red are the ones that achieved statistical significance, right? That's what all of us are looking for. Was it statistically significant? And in these 2 parameters, it does appear to have had some significance. So what were the conclusions, then, of this trial? Is that the surgery in patients with IPF and abnormal acid reflux is safe and well tolerated, right? There were some deaths, but these were deaths in the no surgery population. The results do not demonstrate a statistically significant impact of the surgery on FVC decline. Remember, I showed you those 2 lines, one going down and the other one going a little more down, but just because you see a difference, it did not reach statistical significance. And the overall results are encouraging and may support a larger, well-powered, randomized control study of the surgery in this population. So fuel for thought, right? It's possibility, interesting. It certainly will go on to, I think, a bigger study. Let's move on now. A lot of these you're going to see are photographs. I had the help of one of my colleagues, Dr. Kantha Metapali, in this endeavor when we were invited to do this podcast for all of you. And we took some of the ones that we weren't able to get the slides, and we're going to show you the actual photographs from the meeting. So this is a study sponsored by Promedic, and it's the evaluation of a compound called PBI 4050. It's used in alone or in combination with pirfenidone or nintedanib, and the endpoint was to look at the biomarkers linked to the fibrotic process. We know there are lots of these markers. I joke every day that there's a new one that you have to keep up with, but they selected some to follow. This is the type of drug it is. It targets multiple pathways. And remember when I showed you that first diagram, you could see the complexity. There's so many different parts where you could put a drug in to attack this disease. And this shows you that this drug has the ability to attack in many, many targets. So an advantage because this may be a multifaceted drug to be used. What were the baseline characteristics of the patients? You can see that they are divided between those that just got the drug alone versus those that got the drug with nintedanib, or they got it with pirfenidone, and then the total number of patients were 40. One subject had to withdraw due to an IPF exacerbation. Always important to know, just so you know who's being tested. You'll notice, like as we know about this disease, it's mostly male. Their lung function across the board is very similar, and their duration of disease in the total was about 1.2 years. The results, remember, this is a safety, predominantly safety study. Nobody died. You can see here that, like we know from many of the drugs, the biggest side effect was diarrhea, followed by some others, but basically fairly well-tolerated drug. The results of the lung function, you can see across the board that those that just took the drug alone versus those that took nintedanib and pirfenidone, there were some slight changes in the lung function, but nothing that really was strikingly remarkable. So we have mostly a drug that looks pretty good. We included this slide just so you can see how these studies get analyzed. So everybody doesn't get pooled together, right? We separate out those that just got the drug, those that got it with combination, and those that got it with add-on pirfenidone. And you can see that there are some differences in how these patients did. The ones, if you look across on, you can see the yellow line is just the ones who got the drug, right? And then the ones in the purple dashed line are those that got the drug with an nintedanib. And then the other blue dashed line heading down, and then the light blue at the bottom here are those that got PBI and pirfenidone. Noting that there was some drug interaction with pirfenidone that showed a decline in lung function. However, with nintedanib, you see that there was a possibility that the lung function was being slowed down and that there wasn't this drug-drug interaction that potentially could be a decline. Remember, though, how few patients you're looking at, and that we don't want to make any sweeping conclusions. When I first put this part of the deck together, I had on there proceed with caution. Because we want to be enthusiastic about new drugs, but we want to be careful what we conclude. So then in conclusion then, this is what was presented, was that the PBI 40/50 alone was well tolerated, demonstrated good safety profile, whether it was given with nintedanib and pirfenidone, but you saw some drug-drug interaction. The combination with nintedanib showed more promise, and this is where this company is going forward by using this drug in combination with nintedanib. And in combination with pirfenidone, we already talked about, looks like there's something else going on there, but that its PBI 40/50 significantly increased some of these markers. It increased others in the responders, and in combination, it reduced an inflammatory marker that could be very important for us as we try to understand more about the disease. They looked at a variety of other things as well, including serum plasminogen. So you're going to see a lot of studies. They're going to have a lot of gobbledygook markers that we don't necessarily know what to do with, but they're interesting now as we start to collect the data. As I mentioned, this company is planning to move forward with a phase 3 study that will either use the drug alone or in combination with nintedanib. The next study is Petraxin-2. This was met with a lot of enthusiasm. Petraxin-2 has an interesting mode of action. So it's also called serum amyloid P. It's an immune regulator protein that's part of a group of proteins that are very short in length, but they bind to things called DAMPs. And these are molecules that are important in damaged tissue. So they signal, they're like little magnets to tell you that something's damaged. And this molecule, Petraxin-2, acts upstream, so above, before the fibrosis piece starts. It binds to inflammatory cells that are called monocytes and macrophages. It blocks the proliferation of some of the cells that we don't want to proliferate in the fibrotic environment, you know, where your lung is really changing. And then it induces some smaller changes that may change the whole environment. A very exciting area that clearly the research is just beginning. The drug that's given is a recombinant protein, which means that it's made, and it's been shown in good models now that the fibrosis decreases. And the model that everybody usually uses is bleomycin, and that's the one that's been given to these animals. It's also shown that the concentration of the drug increases in healthy patients, so we know we can give the drug, and we know that the percentage of FVC, lung function, and walk distance in a phase 1 study was done in patients with IPF. You should be careful and always ask about where these initial studies are done, because a lot of them are done in normal volunteers, and we all know that fibrosis patients are different, and it's always better, like this drug, has been tested initially in patients with fibrosis. So this is a placebo-controlled study. It's 24 weeks, and it has 151 patients in the study. So this is the study design. You can see how these things are done. They're mapped out. It looks like a little chart where patients come in, they get randomized. In other words, they don't know which group they're going to go into, and then the study continues throughout the duration. We wanted to show you one of these charts so that you would all be familiar with how the investigators follow along and the patient can follow along when they enroll in a clinical trial. The baseline characteristics look very similar to the other ones that we showed you, mostly male. You can see the diagnosis here was a little bit longer. This group of patients had their disease, whether they were in the drug or the placebo, for even up to 4 years. Their lung functions are the same really in each group. That's always important because you want to be able to compare them. And then if you look at the red in terms of concomitant IPF therapy, there were a substantial number of patients in the drug alone that had concomitant therapy versus the placebo. Remember, these are early studies. We don't want to jump to tremendous conclusions, but we want to be able to see what kind of patients were studied. This is looking at the effect of Pentraxin 2 on lung function. Remember, 28-week study, you see it's significant. The top yellow and orange line with the orange dots is the drug, and then the blue line is the placebo. And once again, you can see the placebo does worse. That's what we'd like to see, and it is significant. Remember, it's a short study, not a huge group of patients. This is looking at lung function. These are bar graphs, really, that show you the blue is the placebo getting worse. These are sort of inverted diagrams, sometimes can confuse all of us. The orange shows that the lung function has less decline in the treated groups. Patients not receiving concurrent pirfenidone or nintedanib in the second column, you see the placebo group compared to the treated group. And then the ones receiving combined drug having a little more decline in the treated group than in the placebo. Safety looks good. Predominantly not diarrhea in this one, although there were some. Most of this is cough and fatigue, common side effects in these clinical trials. And then in conclusion, significant treatment effect versus placebo observed, right, in the lung function. We saw that. No appreciable decline from baseline to week 28. In the walk test was observed. I didn't show you all that data. I just showed you the lung function. But the result is the first clinical trial of the last 25 years to show stabilization in the walk test. But take this with a grain of salt, because we don't necessarily, and the FDA doesn't want us to use the 6-minute as really the definitive point. It's the lung function. And fortunate for this trial, they did show an effect. So it's well tolerated, no notable difference, and the plan is probably to continue on with this study. So I'm going to turn this over now to Sonye to continue on talking about the guidelines and a little bit of more information now on hypersensitivity pneumonitis.
Thanks, Marilyn. I think that my take-home from the studies that you covered is, firstly, that there's an incredible amount of interest and activity in developing new agents that will be even better therapies for IPF than what we have currently. So I think that it's hard to come away from this other than feeling very optimistic about the future for our patients with pulmonary fibrosis. So thank you for covering those studies. What I'd like to do in the next couple of minutes is just talk about a couple of other things. So obviously, therapies are a really important piece of what we do. We're trying to find better ways of treating our patients. But the other thing we really want to do is we want to be able to distinguish between different types of patients, because not everybody who has interstitial lung disease has idiopathic pulmonary fibrosis or IPF. And our sense is that the best outcomes occur when we actually categorize people with the correct diagnosis. So there have been a couple of updates in the diagnostic guidelines for idiopathic pulmonary fibrosis or IPF that I'd like to mention. So the current guidelines that we're using were written in 2011, and they were developed by a group of pulmonary doctors, radiologists, pathologists, who really spend a lot of time taking care of patients with interstitial lung disease. And they were an amazing starting point in trying to help us think about how to diagnose a patient with IPF. But there was still some confusion, particularly particularly when there are some of the characteristics on CT scan missing. And so in the beginning or the end of last year, there was a move by one of our other societies, the Fleischner Society, to actually build better diagnostic guidelines related to CT imaging, which I'm sure many of you are aware is a very common way that we make this diagnosis. And it was primarily around the idea that sometimes when we look at a CT scan, we know this is definitely the pattern that we associate with usual interstitial pneumonia. That's the pattern that can be seen in IPF, although it can be seen in other forms of lung disease as well. And now what the Fleischner Society has done is said, well, you know, part of what we need to do is say that some of these, when we look at the CT scan, we know that they just do not look like UIP, so they are inconsistent with it. And in the ones that were sort of in the intermediate category between we're definitely sure that it was and we're not sure that it was, they've now built two categories, which we hope will actually improve our ability to discriminate amongst patients where we really need to go back and think about the diagnosis again and again. And I think that it was a very important kind of bottom line result from the Fleischner Society update that said, you know, you really need to re-examine the diagnosis at some regular interval to make sure that new information that comes up doesn't actually change the diagnosis. And I think particularly as new medications become available and maybe have different indications, being certain about our diagnosis is going to be even more important. Now, I can tell you that the American Thoracic Society and the European Respiratory Society are also going to release an updated statement on the diagnosis of IPF. And this was discussed briefly at the ATS, but the slides are currently embargoed, which means that I can't share them with you online. I can tell you that as soon as the statement is approved by the European Respiratory Society, that publication will come out. And I think that, again, in line with the Fleischner Society, it's going to be very useful in trying to provide a little bit more guidance as we make diagnostic decisions. So the next thing I want to talk about is about another type of interstitial lung disease called hypersensitivity pneumonitis. Now, we talked a little bit about how do you make a diagnosis of IPF and using CT scans. Well, this is one of these other groups of interstitial lung diseases that is not the same as idiopathic pulmonary fibrosis. And in fact, this is a form that occurs when certain people who are susceptible, are exposed to particular triggers in the environment. Some of the more common triggers are things like birds or bird feathers, mold, grain that is grown on farms, and certain chemicals. And when susceptible people are exposed to these triggers, they can develop a form of interstitial lung disease that is very, very difficult and can be quite similar to IPF in certain ways. But we know that the way we diagnose this needs to be different because in many cases what we can do is get rid of the trigger and it can help people's lungs recover from this injury and potentially not need the therapies that we would use otherwise. So being able to diagnose somebody with hypersensitivity pneumonitis has a lot of implication in terms of then treatment in the future. So I'm going to show you what is called a consensus statement. And what that means is it's not that somebody has done a huge study like some of the ones that Marilyn discussed. What this was actually a process where a group of people who are experts in interstitial lung disease were asked a series of questions. And the way this is done is through what's called a Delphi procedure, which means that each time a question is asked, a group of people answer the question, and then based on their answers, another group is asked a different set of questions, but based on the first set of questions. So it's essentially like trying to get people to agree on something by asking them repeatedly with a more limited set of questions how they actually do what they're doing. So I'm going to show you the flow chart in the next slide. And this is the flow chart. This is a slide from Dr. Julie Morissette, who was the person who ran this study, or this consensus statement. And what you can see is that although there are many different arrows and graphs, this is actually trying to put down on paper how people who are experts in interstitial lung disease make the diagnosis of hypersensitivity pneumonitis. And part of the reason why this kind of process is useful is that when somebody has seen 100 or 1,000 patients who have hypersensitivity pneumonitis, they actually develop a mechanism of thinking about it that can be very useful to be able to transmit to somebody who might see this only maybe 2 or 3 times in a year or even in a career. So what this has done is really developed a pathway that says, firstly, I know that the patient had an exposure. Let's say I know that you work on a chicken farm. You'll go down the pathway that says, yes, I'll do a high-resolution CT scan, and then there will be a whole series of steps after this. Now, I'm not going to go through the details of it, but I think it's important that you all be aware that we really spend a lot of time trying to both think about how we make diagnosis and actually trying to transmit in a way where we can teach other people how to make the diagnosis. And this is one of the strategies for doing it. So I think that over the next year or two, we'll be hearing more about trying to develop a strong consensus statement to help doctors across the world recognize, diagnose, and treat patients who have hypersensitivity pneumonitis. And as I said, this is a fairly complicated form of interstitial lung disease, so I believe that this kind of statement will be helpful. The next thing I'm going to talk about very briefly is actually sort of a new aspect of interstitial lung disease. And I'm just going to preface this by saying that this is something that you'll likely hear about moving forward, because this is a form of lung injury that happens when people are treated for certain forms of cancer using a group of cancer therapeutics called immune checkpoint inhibitors. You probably have actually seen advertisements for this on TV, because they're now a new strategy for how to treat cancers, where essentially what they're doing is giving a drug to allow the body's own immune system to fight off the cancer. And the way they do that is by taking the brakes off of the immune system. So the immune system has essentially a checkpoint that says, hey, don't go crazy and attack this thing because you might damage something. But what the cancer biologists have figured out is that you can take that brake away and you can actually use the immune system to fight off cancers. So these drugs are incredibly valuable for the treatment of cancers and are becoming first line in many different forms of cancer therapy, including lung cancer therapy. Unfortunately, one of the limitations is that in some people, when they receive these treatments for cancer, they develop a very intense form of lung inflammation that we call pneumonitis. So we would like to be able to figure out, firstly, which patients might develop pneumonitis, and secondly, if a person develops pneumonitis, are there ways of treating the person so they could continue to use this very valuable cancer therapy without it causing further damage to the lungs? So a group presented in a poster form about this, and the slides are courtesy of the PI of that, Dr. Karthik Suresh. And the first thing that this table tells you is, okay, well, how many people who get treated with this for, and in this case it was lung cancer, develop a form of pneumonitis. And what you can see right up here is that the number of people in total was about 19%. So that means about 1 in 5 people who got this medication to treat their lung cancer developed some form of this inflammation in the lung, which would potentially make them unable to continue to use the drug. So it's a kind of important complication. And you can see down here that really most people actually got better, but a few people didn't get better. Maybe about a third of people didn't get better. So part of the question is, how do you know whether this will be a problem? So what Dr. Suresh was able to show is that the higher the number for grade, the more severe the form of lung injury. So this is the most severe, this is less severe, this is less severe, and this is the least severe. So you can see that the vast majority of the patients who are represented by these dots, and this is time on this axis, most people never developed any form of pneumonitis. But the people who developed the pneumonitis the earliest, so within about 100 days of therapy, they developed the most severe form. And as people went out farther and farther, the severity of the pneumonitis was less. And those are the kind of things that are important in thinking about who needs to be screened for development of these side effects and whether the side effects might be manageable or whether the patient has to stop the treatment. And I'm just going to end with this slide that Dr. Suresh provided, just showing the increased frequency with which these checkpoint inhibitor medications are being used. So this is actually the frequency of use of the checkpoint inhibitors over the last decade, and this is data from Johns Hopkins. And what you can see is each year the number of people who are being treated is going up. The light gray bar is at the very top, and that shows the number of patients who have this pneumonitis that's a complication. So you can see it's not a lot of people, but it is a percentage, and as the number of people treated with the disease increases, then we'll expect more and more people to be affected by this. So important things to think about now when we have time to be able to figure out strategies for treating it. So I'm going to stop, and I know that Marilyn and I are both very happy to take questions. I see someone had typed, can we submit questions? Absolutely. We'd like to be able to respond to your questions. And I think that Dave Lederer is going to help us by reading us the questions, and we'll try to answer them. Marilyn will talk primarily about things related to clinical trials, and I'll talk primarily about the other data. Thanks very much for being a part of this conversation with us.
Well, thank you both.
Sonye.
Yeah, thank you. That was really fantastic. We do have a few people typing in questions, and we do have some time. So folks on the call, feel free, as Sonye said, to type in any questions you have. So we have a question about VAY 736 for IPF. Are either of you familiar with that?
Yeah, that's the Novartis trial, and that was not presented. That's a trial currently enrolling. You can go to clinicaltrials.gov. This is a trial for patients who are ANA positive without a defined disease. So what is this whole idea about? This is a trial developed by one of the original workers in the field, Dr. Streeter, who's now at Novartis with his group. And what they're trying to understand are those patients with low titers, like you get your blood tested and you'll get a positive antibody. And they'll say, well, you know, you don't have IPF because you have a positive antibody. And they'll say, well, how do you know that? Well, the titer is really low, and these kind of things in our blood, you heard me talk about blood biomarkers, these things show up and they may not be causative of disease. This study is trying to look at that. It's using a molecule that's very similar to another molecule that's being used outside, another drug called Rituxan, and that trial is currently enrolling. So if you'd like more information, you go to clinicaltrials.gov, type your question in, and it'll get you to the Novartis trial, and it'll show you the centers. It'll show you what the primary endpoints are, how many patients are going to be enrolled, and the duration of the study. I can tell you that the first patient in that study has recently been enrolled, so that's an active study.
Great. Thank you so much. Sonye, someone else asked about the difference between pneumonitis and IPF. Do you want to? Yeah.
I'll try to answer that. That's a great question. You know, when we talk about interstitial lung disease, it's like talking about a big category, sort of like if you were talking about flowers, and then we go to, if you said, what is IPF? IPF is maybe like a rose, whereas pneumonitis might be like a lily. So there are different varieties within the category of interstitial lung disease. And while they're different, they often will teach us a lot about the general mechanism by which the lung is damaged. So one of the reasons we're very excited about understanding these different forms like hypersensitivity or the drug-induced pneumonitis is that we think that that knowledge will allow us to help develop better therapies for all patients with all different forms of interstitial lung disease. But they are definitely different and distinct. And in terms of the way they present, while all of them tend to present with some combination of shortness of breath and cough, the context or the environment in which they present is very different. So patients with IPF may develop their symptoms over months or years or decades, whereas the patients who get the drug-induced pneumonitis typically develop those symptoms within about a year, and they all have been exposed to this category of drugs called the immune checkpoint inhibitor drugs. And so when somebody gets exposed to a specific drug and then has a side effect in the lung, that is a very different category than the category of patients who develop this idiopathic pulmonary fibrosis. So I'm sorry if I didn't make that clear.
Those great things. There's a couple questions about OFEV, status of OFEV treatment, and whether it's the most effective drug now. Maybe I'll just quickly address that. So in general, the evidence we have now for OFEV in IPF is the same evidence we've had since 2014. There have been some additional studies of both OFEV and Esbriet, which are nintedanib and pirfenidone. Using the information gained from those original clinical trials that led to approval, I would not say that one drug is proven to be more effective than the other. They're both FDA-approved and effective treatments for IPF.
Yeah. Yeah, David, I would say that there's also never been any head-to-head comparison.
Yeah, that's important.
So that question can't be answered. There have been 2 studies now done in Journey and the MA study by Roche using the drugs together. Sonye and I talked about presenting some of that poster stuff that was at the meeting. But basically, it's published, and the drugs, there's nothing about efficacy in those studies of using them together. It's only about safety.
Yeah. So Marilyn, someone asked about stem cell research, and we have about 12 questions coming up. So I'm going to ask you to give us the summary on stem cells.
The summary on stem cells is that hopefully you'll have a paper soon from us that you've been waiting for a while for a review, but there will be an editorial in Chest that everybody can access online that basically says there's a lot of work to be done. And I think plain and simple is we've published the first safety study. We have approval for a multi-dose study, which we are gearing up to start. That'll be at 5 centers where we'll do a robust phase 2 to try to get an answer to whether or not there's an efficacy. In other words, does it work or doesn't it work? I think the word of caution is the same word of caution that the PFF has put out so well, is that we don't have any studies that say it works or not. So stem cell clinics that are going to charge patients a lot of money and give them vignettes about how it works, there's no data. There's just a ton of work to be done, David. So we're working on it.
Yep. Yeah. Great, thanks. There's another question about circulating inflammatory markers in inhibitor checkpoint inhibitor pneumonitis. Sonye, do you know anything? I don't know anything about that. Do you know about data on any circulating inflammatory markers?
No, it's a very good question, and obviously this is relatively new because these drugs were really just approved a couple of years ago, and so much like Marilyn discussed in one of the clinical trials for IPF, I'm sure that biomarkers are going to become a very important piece of the work on pneumonitis, but we're just a little, the field is a little too new to have a lot of information on that. This one will have to be discussed in a future ATF.
Yeah, thanks. And then another question about that same topic. If you have cancer that was treated with immunotherapy, we have to consider these pneumonitis consequences. I think that's just a point of clarification, which is correct.
Yeah.
Right, and just to be clear, it is specifically the immune checkpoint inhibitors, because there are a variety of different immunotherapies that are currently available for cancer, and this is one category which is a very specific category, just so that it doesn't, nobody gets the impression that it's all of the immune-related cancer therapies.
Yeah, thank you. There's another question about IPF and being treated for advanced colon cancer. I think we probably cannot answer that. That sounds like a very specific question that might be very tailored to an individual person's circumstance. So I apologize that we probably can't comment medically on that. There's also a question for an update on pamrevlumab or FG3019. Those results were presented in September, and have not published. Do either of you know if there's any other update?
No, they have a phase 2 that's completed. They did not present at ATS, and it's unclear what the status is. I'm guessing that there's raising capital to do a bigger study. That's what I'm guessing. But there's no other data on that than what's out there already. Nothing new was presented at ATS.
Yeah, and just so everyone on the call knows, this is a drug or a biologic that inhibits a protein called connective tissue growth factor, and was shown, as Marilyn said, in a phase 2 trial presented in September at one of the medical meetings, showed the slow progression of IPF compared to placebo infusion.
It's probably the drug that's been researched the most. If you look at it, it's been around almost 7 or 8 years now, trying to get it to market. So I'm not sure where that's going.
Yeah, so hopefully we'll hear more.
Yeah.
Thank you. Yeah, so we have a bunch more questions. So where can we find a list of currently identified inflammation biomarkers associated with IPF? That's a little bit of a tall order. There are some review articles in the medical literature that do list inflammatory and other types of proteins and other biomarkers associated with IPF diagnosis and progression. I can't point you towards it at this moment, but there are some, and maybe if you contact our Patient Communication Center, PCC at pulmonaryfibrosis.org, we can try to identify it for you. There's another question about the Fleischner Society statement and periodic CT scans. That statement, I don't believe, mentioned anything about the frequency at which CAT scans should be performed. It was simply about the diagnostic criteria.
Right.
Yeah.
Right, and I think that the key was just that the diagnosis needs to be thought about as new data comes. So having an initial diagnosis doesn't mean that there might not be an opportunity in the future to update the diagnosis, but no, definitely not a specific recommendation regarding frequency of screening CT.
Yeah.
And the other thing is definite stayed definite. The only thing that came into question was some of the CT findings, how probable they might be, right? So that it didn't really change much of what we're going to do, I think, Sonye, with someone who has a definite diagnosis. That criteria wouldn't change, but it would allow those that are in the gray zone, right, to migrate over.
Right, exactly. Just trying to refine the way that the diagnosis is made so that we can most accurately pair diagnosis with therapies. I agree.
Correct.
Yeah. Thank you both. There's another question about an individual who's had a couple of CAT scans and no diagnosis. Again, I apologize. This is a fairly specific medical question about an individual's own medical condition. I don't know that we can address it legally on this. I apologize. It's an interesting question on CBD oil, cannabinoid oil with pirfenidone. Do either of you have any information about that?
No.
I don't have any information, but it's quite interesting. I've been asked about that now by a number of patients, and I wonder if there's something in the patient literature, in the patient support groups that has led to people asking about it. I'd be curious if one of the patients could let us know about that.
Yeah, and again, everyone, you can reach out to us at pcc@pulmonaryfibrosis.org, either with questions or if you have answers. We'd all love answers. Someone asked if they should get a second opinion at a Center for Excellence. So in a general sense, what I would say is that if you are looking for a second opinion, you can find a list of Pulmonary Fibrosis Foundation care centers, as well as other medical centers on the Pulmonary Fibrosis website, which is pulmonaryfibrosis.org, and click on Find Medical Care. You can search for centers in the United States. There's a question about a genomic classifier to distinguish HP from IPF. I don't think we have any data on that, as far as I know.
No, we have one paper several years ago from Moises Selman, just looking at the interesting overlaps in some of the markers of both of those. But as far as a genomic classifier, to my knowledge, there is none.
Yeah.
No, and
yeah,
I think
hopefully more to come, though. Yeah, sorry, go ahead, Sonye.
No, I was just going to say I think that one of the new approaches is to take sort of an agnostic approach and say, we're not sure we know what to call these things, and we're going to look at a bunch of biomarkers and see if we can build new classification categories. So I think we're going to see, there's been a couple of recent publications about that, and I think we'll see more about that, trying to kind of break down the approach to look at whether there are common mechanisms, just very much what Marilyn was saying about Moises Selman's paper.
We know, yeah, I mean, it's an interesting question because we know that they can have a lot of the features that look alike, right? So, yeah, stay tuned. I think that's going to be a new area that you heard a lot about from Sonye.
Yeah, thank you both. Sorry, I think there are a couple questions that have been answered. One is, how long until Pentraxin 2 enters clinical trials? Presumably that's phase 3 clinical trials. Marilyn, do you have any sense of that? I don't know that we know yet.
I don't know. There hasn't been any announcement about that, so I don't know the answer to that. My guess is that they will move forward. They aren't as far as long as the PBI 40/50, so we'll just have to see what happens.
Yeah. Next question is, and we still have plenty of time, so we're doing great. Thanks, everyone, for your fantastic questions. The next one is, previously we were notified that using pirfenidone with nintedanib increases the likelihood of hospitalization and or death. Is that the case?
Where was that? Where?
Yeah,
that's never been presented that I know of.
Yeah, I don't think that's the case at all. There's no data on that I'm aware of.
No, the only study, Dave, is in Journey, which was published by Toby Marr, and that data is not in that paper that I know of.
Yeah, I think there were more side effects in people on combination therapy. And it was a small study, and you know, interesting. We need those kinds of studies to learn more. Yeah.
Right, and the only thing I would add in is that, you know, we want to use medications as safely for our patients as possible, which is why when new medications become available, or as we're doing trials on new medications, we generally recommend that patients try the drugs in the context of the clinical trial. Clinical trials are set up, above all, to assure the safety of our patients. And so, you know, while there may be kind of the sense, well, oh, wow, that's on the market now, I might as well, if one's good, two is better, we actually don't know whether that's true. And until that's really been effectively assessed through clinical trial, I think that most people who are experts would not encourage a patient to expose themselves to the risk of those medications.
Yeah, thanks for saying that. Yep. Next question is, it's actually two questions. Are we mining data about the genetics of IPF sufferers? And the answer to that is a definite yes. There are many groups around the country, including many groups that are working together, and even around the world, that have studied the genetics of the disease and have identified a number of genes that are associated with IPF. And there's work that's continuing to go on with very, very large, even larger studies, again, combining data from many, many different centers around the world. So certainly more to come in that arena in the future. There's also, in the same question, could exposure to coal dust in previous generations lead to genetic changes in the interstitium? And the answer to that is pretty much no, although I'm going to mention one thing. So we don't think that coal dust, as it affects a parent, would then genetically be transmitted to the child. But two things. One is we do know that folks, especially with asbestos, when parents were father was exposed to asbestos, if he happened to bring it home on his clothes and then the kids were exposed, that's a possibility. And then there's this other, and I apologize, guys, for interjecting, but there's this other interesting thing called epigenetics. And epigenetics is when the genes are the same, but the way that the genes are expressed changes in response to something that could have even happened to your parents. So I can't say yes or no that it doesn't change your genes, but it might change the way your genes work. And there's a lot of interest and research going on in that. Marilyn, I think you may be more of an expert in that than I am. Do you have anything to add?
No, I think that's a really important thing. I think the whole epigenetic question is great to bring up because you realize that this disease, because it occurs in an older population, the idea that there are other factors that turn it on, I think are really key. You may inherit your susceptibility perhaps, but what makes you get that disease indeed must happen over time in some level because we don't really see young people getting, at least when we're talking about idiopathic disease, getting that. Now, to the autoimmune diseases and the hundreds of other causes, it may be different, but I think it's very timely to bring up the epigenetics, Dave, and for people to understand that we need to know the surrounding circumstances, right? The question about not just maybe the past exposures, but the lifetime exposures of somebody before they get that disease. And clearly the registries and things that the PSF has started and some of the other companies and some of the other sites to look at this are really going to be important for us in the next few years.
Yeah, thank you. Okay, so interesting question about the new right to try law that I believe has been signed into law.
Yes, I can talk about that.
Yeah, it's for those of you who don't know what that is, this was a law that's now in place that folks who are too sick, so to speak, to enroll in a clinical trial of an experimental medication may be able to get access to that medication outside of the clinical trial. Do one of you want to comment on that?
I can comment on this because it certainly relates to the stem cell world, is that I would proceed with caution and listen to what Sonye had said before about clinical trials. Clinical trials are really important because they provide a protection for the patient, right? The patient's being studied and is really very well scrutinized, watched for everything. Drugs that can appear very good in a phase 1, phase 2 trial, if you've looked at most of the drugs we've studied since 1999, most have failed, evidenced by the fact that you only have 2 approved drugs, right, for the treatment of IPF. And it took many years till October 2014 for those to get approved. Most of the phase 3 trials that we did failed. So I think it's great that there's a right to try. The word of caution, obviously, with stem cells is that there is the risk of death, that if you're so far along in your disease that you don't meet the parameters of a clinical trial, you have to think very carefully. What if you're on the edge of the trial, though, and that there's some data out there that looks promising? Some people would say, take the gamble. You don't meet the qualifications for the trial because the trial has to be very exact, right? And it also has to be safe. You don't want patients to go into trials and die. We're trying to keep people safe and to find out if something, A, is safe, B, if it works. So I think if you're on the cusp and you don't get in, you might think about that avenue, but I would tread very carefully, because just because something is in a trial certainly doesn't mean that it's ever going to get to market. And trust that the process is to protect you and to make sure that we do the right thing for the patients. I think Sonye said that so well, is that these trials are really well designed to really protect who we're bringing in there. And the other thing is that stem cell clinics are charging you, right, to do an experiment on you. When patients come into trials, they don't pay for experimentation. The trial covers everything for them, intentionally so, because we don't know if the drug A is safe or B that works. Now, the A safe is mostly for what are called phase 1 trials. The drugs that work are mostly phase 2, and certainly the definitive trial is the phase 3. So you understand the language behind it, and you understand the purpose of the trial. I think that's also really key.
Thank you for that. We have about 3 minutes left, so we'll try to answer as many of these as we can. The next question is there any news regarding Riplizin as helping reduce scar tissue? I'm actually not familiar with that. Are either of you familiar with that?
Yeah, not in the lung. Not in the lung that I know of. There are several molecules out there to look at scar formation, some of which are being tested in combined models of skin and lung fibrosis. But that one, not that I know of at this time.
Okay. Another question with OFEV, any study on what happens when the dosage is reduced from 150 to 100 milligrams? I'll just quickly say that in a phase 2 trial, both of those doses were studied, but it was really a very small number of patients, I think about 80 patients in each arm. So I'm not sure we can make any strong conclusions about it, but I will say that both doses are available and FDA approved, although the treatment dose is 150 milligrams twice a day. 2011 guidelines, is there something like the Fleischner Society for connective tissue disease related pulmonary fibrosis?
No.
It's a great question, but there isn't. There's going to be a consensus statement that comes out sometime in the next probably 6 months on it, but it will not be done in the same way the Fleischner recommendations were made.
Thanks. And then there's a question about a peptide to reverse scarring developed by Dr. Stephen Idell. I think that's one of many different pathways or proteins or peptides that are being studied in what's called preclinical setting, meaning not yet given to patients in a clinical trial, but one of many. Orphan drug status in the last minute. Maybe I'll just quickly say that when a drug receives orphan drug status, that does not mean it's FDA approved or available. It just is a status it obtains during the approval process, and honestly doesn't mean very much other than that the process may be faster than it would have been otherwise. I think that brings us to the end. It was really great. All these questions were fantastic, and Drs. Danoff and Glassberg, thank you so much for for spending time with us. This was great. I want to thank also the PFF and Lori back at home base, as well as our sponsors, Boehringer Ingelheim and Genentech. So thanks everyone for your time, and we hope to see you at our next webinar. Bye-bye.